Okay, I just wanted to give you all a quick update from Lung Cancer Initiative, especially for those of you that this is your first time joining us. Thank you to our sponsors for making programs like this happen, especially, in these times, we're able to kind of pivot and make these things virtual, and we're very thankful for that. Our mission is to advance survivorship and provide support to those affected by lung cancer through research, education, and access programs. And we recently kind of updated this to add advanced survivorship because patients are living longer and we're seeing more survivors. So we're really excited to have more focus areas on survivor programs. And you can see here what we do. We do a lot of different things. We provide education like this webinar today. We fund research. So we fund research at the major medical institutions in North Carolina. We have survivor programs. If you're a lung cancer survivor, save the date because in the fall, we have 2 different fireside chats, one with Dr. Garst and one with Dr. Milam. So one here in Durham and one in Charlotte, where we just have an opportunity to come and sit down with the doctor and meet other lung cancer survivors. And we have programs like that, all throughout the year. We also have our virtual survivor luncheon, which I think we've got one coming up next week or the next week, the first Wednesday in August, whichever one that is. It's next Wednesday. So yeah, and then we also have access programs like our Access to Care gas card programs, where we give $50 gas cards to lung cancer patients. We do even a lot more than that. So if you have questions about the programs we offer, please let Colleen or I know, and we can send you more information and ways to get plugged in. And this fall is going to be very busy, but we have a lot going on, a lot of exciting things. We have our lunch forwards, which will all be on September 18th. And we have various locations across the state and one in Columbia, South Carolina. These are all the different websites if you want to go ahead and log in and start a team. We're excited about that. We also have our Evening of Hope Gala, which is planned for November 6th. And our next community education event is going to be on October 19th, and that is in partnership with Wake Forest Baptist Health. And yeah, so we have a lot going on in the fall. Again, everything's listed on our website as well, but please let Colleen or I know if you want to know about something specific. And then today we are excited to give updates from ASCO. I think, I've been at Lung Cancer Initiative for 8 years now, and I swear every year there is so much new happening, and I'm just always excited to hear these updates and be able to share that with you all, because you all are, the patients, the families that these updates will be impacting. So I'm really excited to have Dr. Jared Weiss and Dr. Shethal Patel, both from UNC. Dr. Weiss is a former board member of ours, and also just someone that helps us out in so many different things we do, like our scientific advisory committee and things like that. And then Dr. Patel has actually been funded through our research fellows program and also now our career development program. So we are excited to have her on board as well to give kind of updates from her research at UNC. And so I will go ahead and stop sharing. And if we want to just have Dr. Patel get started, we can do that. Yeah, thank you.
Thank you for that very kind introduction and the opportunity to be here. It's great to be hearing updates in ASCO and also have a little opportunity to share some of the research that we have going on here. So as Jenny said, I've been very fortunate to have the support of the Lung Cancer Initiative, both in a fellowship grant as well as recently a career development award. And what I'd like to share today is a little bit of the research that we are working on that's being supported by those efforts. So broadly speaking, I'm very interested in looking at immune therapy and combinations of immune therapy, specifically focusing on lung cancer and lung squamous cancer as a particular interest to see if we can improve treatment outcomes for patients. So as a brief background, we've all heard a lot about immune therapy in lung cancer. What are these immune checkpoints that we're talking about? So immune checkpoints are basically stops that are put on the immune system that prevent the immune cells, the T cells specifically, from recognizing and clearing cancers. And the immune response to cancers is quite complex. So immune checkpoints are just one component of how our cancer cells can avoid the immune response. But these are the ones that have been the most widely used in the clinic and have now become quite standard of care for a lot of lung cancer patients. So the immune checkpoints that we use are antibody drugs that block either PD-1, which is a receptor on T cells, or PD-L1, which is present oftentimes on cancer cells or other immune cells in the tumor microenvironment. And these antibodies basically allow the T cells, which are immune cells in the body, to help recognize and clear cancer cells. But what we've learned is that, unfortunately, these immune checkpoint antibodies, while they have really revolutionized lung cancer treatment, as well as treatments for many other types of cancer, are only effective in a subset of patients. And we really want to have therapies that are more broadly applicable so that patients across the board can benefit from these therapies. And so there's been a lot of interest in trying to understand what are mechanisms of resistance to these immune therapies, which is unfortunately common, either people that never respond to immune therapies at all, or initially respond and then have progression of their cancer. And we've had a particular interest in squamous lung cancers here because there are fewer treatment options often for these patients, because these cancers rarely have targetable alterations. So chemotherapies and immune therapies have really been the mainstay of treatment for these cancers. So how do we improve outcomes for patients with lung cancer for the use of immune therapies? Well, there's a number of different approaches that can be used. One is to identify better biomarkers to try to select for those patients that are really going to respond to these therapies. But fundamentally, what we're hoping to do really is better understand the tumor microenvironment and anti-tumor immune responses so that we can target newer therapies and develop combinations that are effective for more patients. And we've done that through a number of different approaches, one being to develop new models for how we test these combination therapies. So starting first with the approach of selecting patients, this has been the approach that we've used the most so far in the clinic. Here you have a group of patients that if you don't have any kind of biomarker, you treat them all, only a small subset and respond. But if you have a way to select for patients, maybe you can really focus on those patients with the therapy that you're selecting. So the main biomarker that we've used to date for selecting patients for immune therapy with lung cancer really has been PD-L1, which can be present both on tumor cells as well as other immune cells. And there are a number of different antibodies that can be used to identify whether a patient's cancer has high expression or the immune cells in the cancer have high expression for PD-L1. But at the end of the day, PD-L1 is really an indirect marker. It isn't a great predictor in every case that a patient will respond to immune therapy. It helps us certainly enrich patients. But there's really a lot more that we can do. And so what we've been focused on in terms of the research that we've been doing in squamous lung cancer and immune therapies is how can we develop combination approaches by better understanding our patients' cancers to really improve the response rates with patients with these cancers. And so that takes us to try to better understand the tumor microenvironment in each patient. And as this slide illustrates, it's quite complex. And the immune checkpoints such as PD-1 and PD-L1, which are what we have drugs for that are currently approved, as well as CTLA-4 antibodies, are really only a small part of the picture. That when you look at the immune microenvironment of a cancer, there are lots and lots of different cell types that are present, and there are lots of different mechanisms that cancers use to evade the immune response. Two areas that we've been particularly focused on with our research here is the myeloid cell population, as well as metabolism. And I'll focus a little bit on some of the strategies that we're testing with the research supported by LCI. So myeloid cells are another immune cell that can be present in the tumor microenvironment. It can have a number of different roles. They can promote anti-tumor immune responses by foraging cancer cells and really being the sentinels of the immune response, but they can also produce factors that actually suppress the immune response. So one factor that has been investigated as a suppressive mechanism that's related to these myeloid cells is a signal that can be upregulated on cancer cells called CD47. This CD47 is another type of checkpoint that's similar to immune checkpoints, which are targeted in T cells, basically makes cancer cells less visible to the myeloid cell population and allows them to evade detection. So these CD47 checkpoints have been also termed don't eat me signals, because when they are upregulated on cancer cells, they allow the cancer cells to not be recognized and taken up by some of these myeloid cells, which are some of the first cells in the immune system that can often recognize cancer cells as foreign and then allow the anti-tumor immune responses that are more specific through T cells to be generated. So this was one of the areas of focus for my initial fellow project, was to look at the role of the CD47 myeloid checkpoint in our lung squamous cancer models. And one of the reasons we decided to focus on this, in addition to the fact that this is one of the early signals that may allow tumor cells to evade the immune response, is that we'd also seen, looking at expression data for CD47 through the Cancer Genome Atlas, that in lung squamous cancers, when this was highly expressed, the survival for patients was lower. So this suggested that this may be a rational approach to look at to perhaps improve anti-tumor immune responses. So we're looking at CD47 as a mechanism to help stimulate anti-tumor immune responses in combination with more standard approaches, such as radiation and chemotherapy, and then also hopefully planning to test it with novel combinations of antibodies that may improve anti-tumor immune responses by getting the myeloid cells or the immune scavenger cells activated again in patients. So the way that we're doing this is to try to really develop novel models to be able to test these combinations, to see which patient populations, which biomarkers we may be able to use to select patients for combination approaches. And the way that we're doing this is in the lab by using mouse models of lung cancer that have been developed with our lab case collaborators, Dr. Pico, who specifically developed a number of squamous lung cancer models. And the approach that we use to do this is that we actually derive less aggressive lung cancers, then put them into our mouse models and allow them to grow and spread, and then isolate the more aggressive mouse models so that we have a range of different of cell lines that we can use to test our combination approaches. So we've been doing this in the lab for a number of years and have a series of cancer cell lines that have different metastatic potential, which will allow us to test our combination approaches in different models and try to really tease out which markers may be really good markers for seeing which combination approaches are effective. So we'll be using these mouse models, which are immune competent. They have a functional immune system and allows us to test immune combination approaches. The other avenue of research that I've been recently taking up is also to look at tumor metabolism. We've known for a long time that tumors alter the nutrient sources that they use to grow. This can be seen in scans like PET scans, where you can see that cancers take up much more sugar than a lot of the surrounding structures, and that's how we detect these cancers in some cases. But we've learned that nutrients are also really important for the immune cells that are infiltrating the cancers. And one new avenue of research that we're looking at is whether altering the immune microenvironment of cancers also can be done by altering the nutrients that are being used. So we're specifically looking at a new glutamine agonist in the lab. Glutamine is a nutrient that has been shown to be preferentially needed in certain types of lung cancers. And recent evidence also suggests that it's also important in some of the myeloid cell populations that are particularly infiltrated in our lung squamous models. So we're testing to see whether altering the nutrient environment of lung cancers by using these glutamine blocking drugs allows us to improve immune therapy responses as well. So this is another area of focus for some of our research in the lab. So just a bit of a flavor of some of the work we're doing, looking at how myeloid cells may be important in improving immune responses and the lab models that we're using to do it. And thank you to the Lung Cancer Initiative for helping support this work.
Thank you so much, Dr. Patel. it's really exciting to see kind of the outcome of all of the fundraising work that we do and to see the research that we're able to fund through our efforts. So thank you for sharing that. Friendly reminder to everyone here with questions for Dr. Patel, please put them in the Q&A and we will answer those at the end. But now I'm going to turn it over to Dr. Weiss, who is going to share some updates from the recent ASCO conference. So thanks, Dr. Weiss, for being here. I'll turn it over to you.
Okay, hi. I apologize for my technical difficulties getting on a moment ago, and hopefully we'll be able to screen share my slides. So I'm just getting that up, and I'll be grateful to be told if this is not right.
It looks good to me. If you can get to presentation. Oh, we're kind of seeing the back end presentation mode here.
Ah, you're seeing my cheater version. All right, let's see if this works. Are you seeing the good one now?
Yes, there you go.
Okay, so I'm Jared Weiss, and it's a privilege to talk to you today on Best of ASCO Thoracic 2021. I'm also going to cheat a little bit and go over some updates from 2021 that were just a little bit pre-ASCO, because I think you probably want to know about them. So I had the privilege of meeting the author of this book at a conference, and he gave me a copy. It was a really great book. I really enjoyed it because it combined the story of the development of immunotherapy with narratives about some people that are my friends, and in some cases, mentors or that I admire from afar. But the title was a little premature a few years ago when he wrote the book, and happily has become realized. So that realization has occurred in two very exciting ways. First is that we now have more follow-up on the early PD-1 and PD-L1 immunotherapy studies. And early on, when we started to see patients who had no evidence of cancer at 6 months, we were excited. When we started to see it at 12 months, we got really excited. We're now counting in years. And so I think some of us are finally comfortable moving from the words great response to durable control to cure. And so I'm finally, however many years later, comfortable finally saying, I believe we're curing some stage 4 patients with immunotherapy. But an obvious question to ask is, well, with traditionally curable stage disease, can we move the advances made in stage 4 and cure more patients with stage 1 to 3? And there were two pieces of data at ASCO that give a rather optimistic answer to that question. So the first was Checkmate 816. This was a study that took patients with newly diagnosed stage 1B to 3A non-small cell lung cancer, or in plainer English, the stages for which the current standard of care is surgery plus chemotherapy, or a standard of care is surgery plus chemotherapy, and randomized them to the standard of care shown at bottom, which was 4 cycles of chemotherapy following their surgery. Or, excuse me, I'm misspeaking. Randomize them before surgery to either a standard 3 cycles, which is 1 standard of care, or that same standard chemotherapy plus the PD-1 inhibitor nivolumab, or for those who like to watch TV, Opdivo. And then all the patients got scanned again, they went to their surgery, and whatever their doc felt indicated after was allowed. Here's the flow of patients. First, reassuringly, in the experimental arm, most patients went to surgery, 83%. Now, a reasonable question here to ask is, well, what about the other 17%? There are 2 answers to that. First, we'll dive into what happened to them. But second, that's about on par with what happens if you don't do anything before surgery. People do fail to receive complete therapy. Why did it happen in this study? Well, very reassuringly, disease progression was a rare cause. It was 7% of patients. That's both low on an absolute basis and lower than with chemo alone, just as you'd expect. Opdivo is an active drug. Reassuringly, adverse events were rare as a cause for not going to surgery in both arms, 1%. And then other. And other incorporates most of the patients in both arms, or at least over half. And what other is representing is either that they start the surgery and then it's not resectable, there's a reason to abort, or patient choice. And again, this happens even in the absence of doing something before surgery. And then the primary endpoint that we got data on here was pathologic complete response rate. So a definition, pathologic complete response means that the cancer is taken out. Pathologist looks at it under the microscope and says, there are no living cancer cells left here. Here's those rates divided out by stage. As you can see in the gray bars, for all stages, it was pretty rare with chemotherapy alone, and we've known that for a very long time. What's exciting here is that for all stages, there's a very real rate of pathologic complete response, meaning no visible viable cells on pathology in the chemoimmunotherapy groups. And of course, the rate is higher with earlier stage disease compared to later stage disease, because you're starting with more cancer, with more advanced disease, there's farther to go. But even at the more advanced stages here, 2 and 3, nearly a quarter of patients having a pathologic complete response. What about the total populations? What about what happened to those without a pathologic complete response? You're looking here at a type of data representation called a waterfall plot. So every patient on a waterfall plot is a vertical bar. Any vertical bar north of 0, which you're happily not seeing here, is tumor growth and percentage of growth. And anything south of 0 is shrinkage, with the extent, how far down the bar goes representing the percentage shrinkage. What you see here is we do have real shrinkage with chemotherapy in both early stage and at bottom, more advanced stage patients. And what I think is overwhelmingly clear is that that response is more common with the nivolumab added, and the depth of the response, the number of patients getting to the bottom here, is quite a bit more favorable. And interestingly, the correlation between what was seen on imaging and what was seen on pathology was not that great, consistent with prior data. Dead cancer doesn't look that different from living cancer, at least until the garbage proof the immune system has time to clean it up. And even still, the fibrosis and scarring that can be left behind can create an abnormal radiographic appearance that can last for a lifetime, even in happily cured patients. So that's what happened when the PD-1 inhibitor nivolumab was added to chemotherapy. We had a nice rate of pathologic complete response. We have a nice rate of tumor regression. It's too early to address whether this reduced recurrence or improved survival. I would say this data is highly promising that the ultimate answer would be yes, but we have to await further data to see that proof. Now, this is what happens when you add immunotherapy to chemotherapy before resection. We know from our old literature that doing the chemo before or after are similarly effective. It may or may not be the same answer with immunotherapy, but I have for you as well early results from what happens when you give immunotherapy after you've finished surgery followed by chemotherapy, another acceptable standard of care. And that's the Empower 010 data that happened to have been done with the PD-L1 inhibitor atezolizumab. Here's the design of the study. They took patients with stage 1B to 3A non-small cell lung cancer. So again, the stages for which chemotherapy is a standard of care. Everyone got chemotherapy here. So there'll be other studies you may see in the future that substitute immunotherapy for chemo. It's a worthy question. The way this was done was everyone got the standard of care, which is to say the surgery, then the chemo, and then they were randomized to either the immunotherapy or not. The primary endpoint was actually, the primary endpoint of this study was actually a subpopulation of the total patient studied. When a study is designed, the company has an agreement, makes an agreement with the FDA about how the analysis plan will be done, which later affects how drugs are approvable. So in this case, Genentech and the FDA agreed that while a broader study population would be studied, the primary endpoint would be by stage, those who were 2 and 3A, so not the stage 1 patients with tumors of at least 4 centimeters, and whose PD-L1 was at least positive, so not the patients whose tumors did not express PD-L1 at all. And what we see here is a rather meaningful improvement in disease-free survival in the early data here. Sorry if you're seeing my reminder as well. And it's at any time point you look at, right? The curves diverge rather early, which is nice. They stay separated. And as the tails start to flatten, which are the patients we hope are cured, at least to the latest follow-up we have, when the numbers start to get thin and we need more follow-up, they seem to stay flat and nicely separated, suggesting that really more people probably are being cured with the intervention. Of course, really knowing that and knowing whether survival is improved will take time. The other question that I ask with my critical hat on is whether even in this subgroup population, are all patients benefiting? This is a really important question because while immunotherapy has fewer side effects than chemotherapy, there's very real rates of immune-related adverse events. So inflammatory stuff coming from the immunotherapy. And so if there are populations who aren't going to derive benefit, we very much want to know that so that we can both look for other things for those folks and critically not expose them to side effects if they're not going to derive benefit. And so we have some subgroup analysis from this study. What we see here is that for patients whose PD-L1 is negative, whose tumors are not expressing PD-L1, there doesn't seem to be any benefit of adding atezolizumab. Of course, we all wish this wasn't true, but we have to look at the data honestly as it is again, or else those who make these decisions, which are to say doctors, patients, their families, and those who support them are going to make the wrong decision, which is to say take a risk of adverse events without potential for gain. In the patients whose PD-L1 was at least 50%, the benefit was dramatic, and that's quite wonderful. I mean, that's a really, really nice advantage. What's harder are the patients with a PD-L1 of 1 to 49, because we get here what I sometimes call a Russian nested doll analysis. So my youngest daughter, Charlotte, has these dolls. There's one inside the other, inside the other, inside the other, called Russian nested doll. She plays with it every night before she goes to sleep. I have no idea why. She just takes it apart, puts it back together, and makes her happy. And that's the kind of analysis we have here, because in this at least 1% population, half of those patients are the at least 50s. Right? What would have been much more useful to me as a clinician trying to know which patients I can help is instead of getting that Russian nested doll analysis, to have what you'd call a discrete analysis with the 1 to 49% patients presented on this line instead of the at least 1. I do look at data a lot, and my best guess is that in the 1 to 49s, when we eventually see that data, looking at these numbers, my best guess is that there's either very, very small benefit or no benefit. But I look forward to having that data presented so we can know the right thing to do. We do have early survival analysis, and here they showed it to us in the at least 1% 2 to 3A patients, curve starting to diverge, starting to show a survival benefit. But if you go to the all randomized 2 to 3As, so that's to say, regardless of PD-1, you have no benefit. And when you go to this total study population, you have no benefit. So maybe there's even harm to survival in giving the immunotherapy to patients who don't actually benefit. And so I would really call upon Genentech to release this data in its discrete form. And I suspect that when this is submitted for publications, the reviewers will do their job and oblige that. So that's what I have for stage 1 through 3 updates at ASCO. In summary, immunotherapy is really promising to improve survival for these stages of patients. In my opinion, there is legitimate promise here to improve both cure rate and survival. And of course, more follow-up and discrete data needed. I don't think there's a great hint as to whether it's better to give immunotherapy before surgery or after. We already know that when chemoradiotherapy is done for unresectable stage 3, there's certainly a dramatic benefit to a year of PD-L1 inhibition after that. So I'm going to move quickly through the intro to targeted therapy because I think it's an inspirational story you're already rather familiar with, but I'll remind you that 20 years ago, when gefitinib was a new drug and we didn't know what it targeted, there were patients who within 5 days, this is 5 days apart, these x-rays, had these dramatic responses to targeted therapy. We now expect these as the norm. We see this snowstorm cancer appearance on the x-ray clearing up within 5 days. And of course, patients cough and shortness of breath resolved. From a historic view, we didn't really know that it was EGFR mutation at the time driving the benefit. We had, these are progression-free survival curves. So the x-axis is time, the y-axis is proportion of patients without tumor growth or death. But when these curves cross over each other, that's not to say that the two drugs work the same. There are many explanations to that. The most common one by far is that you have two populations, one doing better with one treatment, one doing better with the other, and you haven't figured out how to divide them out yet. And that's in fact what happened. In the EGFR mutation negative patients, gefitinib was just a diarrhea and rash-inducing placebo. But the aha moment was that in those with mutation, gefitinib was better than chemo, and better in every way that a treatment can be better. It's less toxic, it's more effective, as these curves show, and of course, it's a pill instead of being IV. Now, what's been delightful in the last year is this story repeating itself again and again and again. For some reason, it's absolutely mandatory to report the breakdown of lung adenocarcinoma driver mutations in pie format. I guess whoever started presenting it this way was really into pie. Sorry to do that around lunchtime. And also sorry if that's not funny on Zoom. I have no idea if anyone is laughing or not, but at least you can't throw tomatoes over Zoom. Any rate, what's delightful in the evolution of these pie charts over time is that the proportion of the pie chart that is represented by unknown or not actionable has dramatically shrunk over time. And we now have drugs against all kinds of targets that we didn't even just a year ago. In the last year alone, we've gotten approval for 2 drugs against RET. We've gotten approval for a KRAS G12C inhibitor. People have been working on KRAS for since the dawn of the internet. And I don't know if, it did make it to the slide. And a new monoclonal antibody against EGFR exon 20 insertion. So really, really nice advances here. But we are advocates for patients here. I unfortunately need to share with you some data that makes me kind of sad, if not more honestly, rather angry, but that as advocates, you really just need to know about. So 2 things need to happen to bring the benefit of targeted therapy to an individual cancer patient. Number 1, they need to get testing that finds the mutation. And number 2, they need to get the actual drug that then actions it. And on both fronts, I have some depressing news for you that means that all of us have a lot more work to do. So at ASCO, we saw data on rates of community testing of 5 common biomarkers: ALK, BRAF, EGR, ROS1, and PDL1. And what we see here is that the rate of testing for all 5 of these biomarkers, and there are, excuse me, is this 5? Yeah, 5 biomarkers, and there are more since this work was done, was about half of patients. And disturbingly, while there might have been some improvement from 2018 to 2019, since 2019, there's been no movement whatsoever for increasing that rate. Half of patients who are supposed to get biomarker testing are not getting it. That is a massive problem, right? No matter how hard the scientists work and develop all these new targets and the drug companies develop new drugs against them, if patients are not actually getting them, those advances are not reaching those patients. This is a huge, huge problem. There are racial disparities in this problem, in particular for Black patients. Black patients are not getting next generation sequencing frequently enough, next generation being the good testing. We'll talk about that in a moment. And Black patients are not being offered trials enough. And one of the important drivers of Black patients not being offered trials is not getting the testing that would show the changes that are actionable on trials. So a big problem and a problem with racial disparity. On the treatment side, we're doing poorly as well. There was a paper that came out in, I think, late 2019 in JAMA looking at this. And the paper kind of buried what I thought was the most important part, which was the non-actioning rate. That rate was less than half of the time in this study. When an actionable driver was found, the patient got the drug. So half not being tested, then of those tested, half not getting drug, right? This is a tragedy. And the editorial he wrote for, I think it was Medscape, if I remember right, really hit the nail on the head in a rather brutal fashion. Here's the data from that study. So it was roughly half, as I said, or more than half that didn't get action therapy, but it really mattered, right? So those who got the recommended therapy, shown here in blue, lived longer than those who did not. This jives with historic data. Historic data shown at bottom for Melissa Johnson. Those who, in the gray curve here, those who had an actionable biomarker and got the appropriate targeted therapy lived longer than those without an actionable biomarker. But importantly, those without a driver mutation lived the same amount of time as those with a driver who didn't get the appropriate drug. And so what this means is there's no advantage to having a driver mutation unless the patient actually gets the appropriate drug. This makes common sense, but here's the proof that it's true. It's not all about survival, right? There are 2 major reasons that most cancer patients take drugs for stage 4 disease. The obvious one, they want to live longer, and perhaps the most important one, they want to preserve and improve quality of life. So you're looking here at a historic study that was just the easiest to cleanly show the point. These were patients back when osimertinib wasn't a frontline drug and was only used for people who had T790M. This was a study that randomized patients to the targeted therapy osimertinib or to chemotherapy. And what we see is that across all of the common lung cancer symptoms, quality of life was improved with osimertinib compared to chemotherapy. It works better. And I don't think I need to show you the data that it's dramatically less toxic. Those are the two sides of physical quality of life, right? The two biggest drivers are toxicity of drugs, which are better with targeted therapy, and disease control, stopping the suffering from the cancer, which is also better there. NCCN is the Bible for community oncologists about the right thing to do. They strongly advise broad molecular testing. They go a little further in saying what it is, but in my opinion, they don't go nearly far enough in telling our community docs what to do. What is it to actually be broad? And by the way, that's something called a COVID dress. I guess it's the distance you need to keep away. And so I want to distinguish for you 3 levels of testing. And I'm going to apologize in advance. I'm about to dive a little bit into the weeds of molecular testing methods, but I'm doing it because it matters for patients and for advocates. So the first distinction I want to make is between a la carte testing and next generation sequencing. A la carte is just like in the restaurant, the doc orders what he or she wants. Next gen just gets everything. Here's how it roughly looks. Typical a la carte testing is EGFR, usually ALK, sometimes ROS1, and usually not much more. Next gen gives you just about everything. But in addition, one of its weaknesses is it gives you several hundred genes with questionable meaning, because one of the ways the laboratory companies compete against each other for doctors' business is to say, oh, we test 200 useless genes, we test 400 useless genes. Of course, they don't call them useless. They just advertise the number that they test. Now, I wish I could stop there at a la carte versus next gen, but there is one more important distinction to make, which is next gen versus next gen with an RNA fusion. And I may be making Dr. Patel and anyone else with a PhD on the call cringe by the oversimplification here, but my stoplight is just to give a quick view of how good the simpler testing is for getting stuff. So next gen, the common next gen that's ordered is really good if you have a mutation. So that's what we know from the old days, one simple change in the sequence of the DNA. So things like EGFR, KRAS. For old known fusions like ALK and ROS1, the a la carte testing with FISH is pretty good, but it's a little bit better if you have an RNA fusion panel. Red, I have squarely in the middle of this yellow because DNA-only next-gen certainly can pick it up, but there are some unknown fusion partners for which the RNA fusion panel will get it where the DNA alone does not. And when you get into NTRK and MET, all of the commercial next-gen panels say they get them, but actually they're missing a lot of NTRK and MET if you don't have an RNA fusion panel. Now, I've criticized NCCN for not going far enough in saying the right thing to do. Before I show you the next slide, I want to be clear that I have absolutely no financial or other conflict of interest with any lab testing company whatsoever, but I'm about to list brand names in order to get to that final answer. So these are the ways that I think get you the good testing, the RNA fusion panel. So you can have a DNA next gen panel and add on a bespoke panel, a bespoke Archer panel. Some of the very famous huge places have this. It's a wonderful way to do it. But for those of us not in the stratosphere, the major way are these 3 tests here at bottom. These are the 3 commercial tests that, in my opinion, do it well. Tempus is what we use at my institution. Keras is also a good test. Foundation Medicine is the most commonly used next-gen sequencing in the US. But the panel used is the CDX panel. That's the normal one. If you want the good stuff, you actually need the heme panel. It's poorly named, but that's the panel that has the good RNA fusion. So I'm over time, so I'm going to fly through the last few slides and have this mostly for your reference, but we've had a number of drugs approved in the last year. We've had 2 RET drugs approved. This one is selpercatinib, just because I have easier access to the data to copy paste it in here. Gorgeous waterfall plot, beautiful control in the brain, even better control when given as the first treatment for patients, and a gorgeous progression-free survival curve consistent with next generation targeted therapy. The drug is the data is similarly beautiful for pralsetinib. Amivantamab is a bispecific monoclonal antibody. In plain English, it's IV against EGFR and MET. And we saw data at ASCO for its activity against exon 20 insertion EGFR. Here's the toxicity tables for your reference. Here are the spider plots. Every patient is represented as a horizontal line. When the cancer shrinks, the line goes down. When it grows, it goes up. So it allows you to see at a glance the kinetics over time. The details I leave for your reference, but suffice to say the drug is active, and exon 20 EGFR is now a cleanly actionable target. Response rate here was 40%. We're coming straight out of UNC, both preclinically from the lab of Ned Sharpless, and then for running the key trial is trilaciclib. This is an IV short-acting CDK4/6 inhibitor. In plainer English, it's a new drug that you give before small cell chemo that holds the bone marrow progenitors that make blood cells out of cycle while the chemo is going by, so they're not poisoned by it. So it's a quality of life drug, something we've needed more of in lung cancer for a long time. In the interest of time, I'm just showing you the pooled data. All of the blood counts of interest were notably improved. And we have a clean story from its mechanism to the reduction, to the preservation of blood counts, to reduction of hematologic adverse events. And of course, the reason, in my opinion, we should all care, to improvement in quality of life, particularly fatigue, a problem that vexes my patients and that I'm not very equipped with other tools to deal with. Importantly, safety here is the opposite. This is a quality of life drug. So safety isn't, does it harm toxicity? Toxicity is less. The question, the safety question is, does that harm the disease-related outcomes? And no, there's absolutely no impact on progression-free or overall survival. You wouldn't expect it based on mechanism in either direction, but it's reassuring to see that there isn't. It's a pure quality of life drug, at least in small cell lung cancer. I apologize for going 6 minutes over, as well as for being late getting on, but I'm now happy to answer any questions that anybody has, if I'm allowed, if time allows. And if not, I'm happy to answer them by email. It's jared_weiss@med.unc.edu.
Thank you so much, Dr. Weiss. That was great. And I just, personally love all the information about the biomarker testing. At Lung Cancer Initiative, that's something that we're always doing, trying to raise awareness, make sure people know. But I just have kind of a question/comment, just so we're all clear. Who should have comprehensive biomarker testing? What stage? And if there's a recurrence, should they be tested again? And can you stop sharing your screen?
That last one's real easy. Stop share. Here we go. So every patient, so the easy statement is every patient with stage 4 non-squamous, non-small cell lung cancer should have comprehensive molecular testing. But I'm going to go a step further and say, and strike out the words comprehensive molecular testing and put in there DNA, next generation sequencing with a good RNA fusion panel, parenthesis, commercially that's Tempus, Caris, or Foundation heme. In my opinion, a patient with mixed histology or any doubt about histology and stage 4 disease should also have comprehensive molecular testing of the type I specified. And any non-smoker or almost non-smoker with supposedly squamous disease should have comprehensive testing of the type specified. And then it gets a little bit harder what to do with stage 1 through 3 patients. So there is, it's beyond our scope right now, but there's now data that osimertinib can improve disease, dramatically improve disease-free survival in patients with EGFR mutation after surgery. And so in my opinion, now every stage 1 through 3 patient should be tested, because the uncontroversial reason for me is that recurrence rate is real. We know that some patients recur, and we know that molecular testing takes longer to come back than any of us would like, often a month or more. And so at the minimum, in my practice, I'm testing all those patients so that in case they recur, I'm pre-armed to know what to do, instead of choosing between poisons, which is to say chemo, or watching the cancer grow for a few weeks. What's much more controversial is what you should do with those results of that testing if you get back EGFR. I have significant issues with the way that study was conducted, such that I don't think the results will ever tell me if we're really improving cure or survival in those patients. I think that we're going to get data publicly disclosed that claim to. I don't think it's ever going to answer that question for me, and so I'm really vexed as to what to do with that data. Should they be tested? Absolutely, because in case of recurrence alone, that's a good enough reason. I'll leave for another day the controversy over what to do with it. It's not easy for doctors and patients.
Well, and what about for patients that you have that they get tested, but there's not currently a therapy, say KRAS, a year or two ago? Can you go back to those patients now? And like, how do you handle that as a provider?
So as a provider, the way so if you look at why people don't get targeted therapy, you can find, and I found this in my consultative practice, I found this in practice taking over for others when they've left, that the report can get buried in charts because these reports don't integrate well with the medical record, or at least in the past they didn't. That's a problem that people are solving on a systems level. But the first thing is that if the report was lost and then found, or if a change becomes actionable, you can action it at that point. How do I deal with this in my practice so that I don't forget? Because I'm severely ADHD, right? I will forget things. I really am. Diagnosed in childhood hasn't changed. How do I deal with that to make sure, I'm sure I'm not alone, right? Other people who, even without a diagnosis, miss things, forget things. How do you deal with that? Well, you need to make a systems approach so that you can't muck it up. The way I do this in my practice is that I keep the basic pathology carried forward in every note from the moment I meet the patient until my last visit with them. And so it says pathology, adenocarcinoma of the lung, comma, KRAS G12A, comma, PD-L1, whatever it is. And then if, God willing, 2 years from now, we get a great KRAS G12A drug, the next time I see that patient, it's hitting me atop the head, they have KRAS G12A, and it's easy to then cycle back and give them drug.
Awesome, thank you. Well, oh, sorry, go ahead, Dr.
Patel.
Patel.
On that too.
Oh, no, I was just going to mention, I totally agree with Jared was saying. And then to answer your question about retesting, I think it really depends on what the panel was that they got, going to Jared's point about how comprehensive it was. If the patient had a pretty comprehensive panel when they were initially diagnosed and just didn't have something that we have a target for, then it may not be reasonable to retest. But if it was a much more limited panel, then certainly that makes sense if they're, going back to some of these broader panels that are looking more comprehensively for fusions to look at those. If you identify a driver, oftentimes that will be present at recurrence, but the only reason to retest in that case would be if you targeted that driver, then there may be resistance mechanisms that you could find by doing a new biopsy or a new liquid biopsy and testing at that point.
So, I want to just say one more thing about that. I agree rather strongly. I want to add one thing. There are two ways the report can be negative, right? So the report can be negative in that it finds a driver mutation that I can't action. In this case, I'm sad, but I'm done, right? So in my KRAS G12A, right, if they got old school testing and it's KRAS G12A and then cancer recurs or grows later, there's no point in retesting. You're not going to find something you can use to help that patient. The answer may be sad, but you're done, you know it. The other is that if you never found the driver. So for an example from my practice just this week is a patient who had what I would call old school DNA only next gen, and was retested and found to have RET with a previously unknown fusion partner, right? So that's diving painfully into the weeds of molecular analysis, but that human being is going to benefit from it, right? So that's that patient did not have an actionable driver, and that was worth sending the old tissue for retesting. But when there's existing tissue in such a situation, you don't need to stick another needle into the person with all the discomfort and risks of that. If there's adequate tissue from before, you can send that off. The reasons for retesting are if you are looking for resistance change. So like if you have a patient with EGFR mutation, drug works for 2 years and then it stops working, and you're asking the question, what's changed that I might exploit to help the patient? That's when you rebiopsy or send liquid again. And that distinction I'm going to leave for another day in the interest of time, unless someone asks about it.
Awesome, thank you. Yeah, we do have a couple questions in the Q&A, so we'll get through as many as we can before we hit 1 o'clock. So this first one is for Dr. Weiss, asking, in your trials, did patients get immunotherapy after their chemo treatment or during chemo treatment? Is there a difference on how the patient can tolerate the side effects if they get the chemo and immunotherapy separately?
It's a great question, and I don't know. We have data of adding immunotherapy to chemo before surgery. We have data in immuno after. It's going to take years to unravel the right sequence of how to do things and then who to do it. It took years in stage 4 disease. It's a high quality problem having to untangle the details of our advances, but with apologies, we don't have the answer for that question yet. It's something future studies will have to address. I can scroll through these. Will you have access to the slide deck? I'm happy to share it. They have it at LCI. You have my permission to share with anyone who can help, and I'm happy to answer questions about it. What about guarded molecular testing? Not good, question mark. Shuffle, you want to take one since I've been doing most of the talking? And since you've got the PhD and I don't?
Guarded, it certainly is very helpful in a lot of ways. So one, if you don't have adequate tissue to get molecular testing, it has a really rapid turnaround time. The couple of limitations that are important just to think about are the sensitivity of the approach. So if you look even in stage 4 patients that have metastatic disease, you're not going to be able to detect that circulating tumor DNA in 100% of patients, even if they may have circulating material or maybe just below the level of detection of the assays that we have. So that can be a limitation. And then because it is a DNA-based test, sometimes you can have limitations in terms of detecting fusion. So there's a couple of caveats to think about, but it is certainly very valuable testing. And if you do guardant testing and find in alterations, study have clearly shown that it's actionable. So if you find it in the blood, those alterations are actionable and you're done. But if you are, like Jared was saying, if it's negative, I wouldn't necessarily stop at that point because you may not have the sensitivity of detecting things that are actually there. And I think somebody else had a question about resistance testing, after you've progressed on a targeted therapy. And certainly that is another area where doing repeat either tissue testing or guardant testing can be very helpful in identifying mechanisms of resistance that can really be targeted and provide meaningful benefit with adding targeted therapies for patients. So that's definitely a reason to consider repeat testing, again, with the issues of not having quite as good a sensitivity and potentially missing certain types of genetic changes with guardant or circulating tumor DNA approaches.
Yeah, I very much agree. I use liquid testing in my practice all the time. It's useful when there's not enough tissue. It's useful for its speed. It's much faster than tissue testing. It's just when you don't get an answer, you do have to drive further with tissue. And I would say, again, exploiting the fact that I have no conflict of interest with any lab company, in order to be allowed to answer the question, I think guardant is a particularly good liquid test, in part because of its speed. You can have an answer within days, which means patient benefit faster.
Absolutely. Thank you. I have a personal question. I did not put it in the Q&A, so you guys can't see it. But were there any updates around small cell lung cancer that were presented this year?
So there are two updates in small cell. One I showed to you is trilaciclib, a drug to preserve blood counts to improve quality of life in small cell patients treated with carbo-topo-atezo or with topotecan, or if for ever any reason there's just to give carbo-topo, there's a study there too. That's really inspiring to me because we haven't had a quality of life drug or a meaningful one, let's say, in a long time for any lung cancer. And it's nice to see focus there. It's of course particularly gratifying to me because it came out of UNC. So go UNC. And the other advance this year is lurbinectedin, which is an alkylating inhibitor, which is to say a new chemo that looks a little less toxic and a little less, a little more effective than topotecan. And certainly because it acts by a different mechanism, is an addition to our therapeutic armamentarium.
Awesome, thank you. That one went over my head as we sprinted to the finish line there.
Two new drugs, one new chemo, one new supportive care drug.
Awesome. Okay, there's another question that just came through for Dr. Weiss. You mentioned how low testing rates are. How do we close the gap on molecular testing in community practice? That's an easy question to answer, right?
Actually, I don't think so at all. I think that's a really hard question. I've been working on it for more than a decade, including efforts with LCI before it was called LCI. And I agree with Dr. West's editorial. How the heck have we failed so miserably? I've been running around the country trying to educate docs with CME, as have other docs like Dr. Patel. All of us have been running around trying to advocate On the other side of my volunteer life, which is cancergrace.org, I've been trying to directly educate patients and their families. So someone in the room, give it another shot on goal for someone in the room to know the right thing to do. And the rates are still pathetically low. Certainly we'll keep doing the advocacy and education efforts we're doing, but it's dishonest to claim that's the complete answer. Personally, I would love to see see some malpractice cases where non-testing is something people are sued for in malpractice suits, because that will make doctors pay attention and do the right thing. I'm sorry to end on such a brutally negative note, but what we're doing is not good enough. We need new ideas.
Well, I'll turn it around and end it on a positive note that we actually have a community education program on biomarker testing coming up in November, which is Lung Cancer Awareness Month. So everybody come out. We're planning to do it in person at the Solution Center in Durham if you're in the Triangle area. But yeah, this is an active priority for us, and we're doing everything that we can to help people, empower people with information and education to advocate for biomarker testing in their care. So thank you both so much for sharing all of this great information in such a helpful way where people, of a lay background can understand. I definitely learned a lot, and it's great to be able to keep up with lung cancer research through you guys. And I just want to let everyone know that this was recorded. So I'll be sharing the recording of this presentation with all of you all in the next couple of days. So keep an eye out for that. I'll also share the slides with our presenters' permission, as well as their contact information if you have any further questions. But anything else, Jenny? Okay. All right. Thanks, guys. I hope you all enjoy the rest of your day.